Clueless in the pause. Whether you're peri, meno, or post-pause, I'm here every week to talk all things menopause, the things we're all thinking about but not talking about. But trust me, someone somewhere is feeling pretty much the same that you're feeling. I'm Karen Thom, a women's life coach, and at 44, starting to feel perimenopausal symptoms. Each week, I'll be joined by an expert in their field, and we'll delve into pressing topics like, why do I hate my husband for 3 days every month? Why do I feel my internal thermometer is bogged off to the Caribbean? Why do I need strength training in my life? And why are my periods flooding, ruining my best genes? We'll dive into the symptoms, why we experience them, and provide budget-friendly tips to help combat them. Get in touch, let us know how you're feeling, and send us your questions. We'll be answering them throughout the series. Hey everybody, this week on Clueless in the Pause, I'm talking to Dr Manju Navani, a menopause specialist and trainer. Recognised by the British Menopause Society, she holds an Advanced Menopause Certificate, which is an acknowledgement of her expertise in this condition. In her role as a BMS accredited trainer, she has assessed GPs and gynaecologists in the basic and advanced menopause module and given presentations on menopause to healthcare professionals and patient groups. Dr Navani has led the NHS Menopause Service in Stockport for 16 years and managed complex menopause cases referred by GPs. Dr Navani has over 25 years of experience in managing menopause patients. She currently works in a GP practice as a menopause, contraception, sexual health specialist, including women's health. She also runs her private menopause clinic, Navani Menopause. She has written the menopause guidelines for healthcare professionals in Stockport and Manchester and regularly updates the HR prescribing formulary. So, all in all, I think we can say we are safely in the hands of an expert talking to Dr. Navani. Really excited to see how this conversation develops. Brilliant. I'm really excited to have our chat this week, Manju. I've been looking forward to this for quite some time now. So we're going to talk about menopause from a gynecological point of view. But welcome to the podcast, Manju.
Hello, Karen. Thanks for inviting me. I'm Dr. Manju Navani, and I'm a gynecologist, basically working in the community, and a menopause specialist, accredited by the British Menopause Society, and I'm also a menopause trainer. I deal with complex menopause cases. I worked in Stockport all my life for the NHS, and I see patients which have been referred by their GP with complex medical problem, gynecological problems, cancers, who are referred for hormone replacement therapy or alternatives to hormone replacement therapy if they can't have it. The NHS clinic was based in Stockport, which I was a lead for 15 years. And I currently work in a GP practice in Stockport, where I deal with women's health, basically. So menopause, contraception, sexual health, again, common gynecological problems which can be managed in the community. I also run a private menopause clinic called the Navani Menopause Clinic. And this is a virtual clinic where patients can self-book online. And they have a 1-hour consultation with me, following which I would write to their GP to prescribe the HRT. So I do see patients in this clinic who are desiring to have testosterone, because a lot of GPs on the NHS do not prescribe testosterone. And so that's one of the referral indications to my clinic.
Are people self-referring themselves for testosterone, that they feel that's what they need, or they've been diagnosed from a doctor or something?
Okay, so testosterone, the indication for testosterone as per the British Menopause Society guideline is for low sex drive if it hasn't improved with hormone replacement therapy. So they are on the right HRT, which has been optimized. And if their sex drive hasn't improved, and if they have no other cause for the low sex drive, so we know sex drive is very complex. And there can be a lot of reasons, right, from relationship issues to stresses of life, whether they have comorbidities, illnesses, they could be having just vaginal dryness and soreness, which is putting them off sex. So there are a lot of causes of sex drive. But if there is, all the other causes have been ruled out and they are on HRT, then they can have testosterone to improve sex drive. So that's the main indication for testosterone. However, we know that testosterone helps with other conditions, like it helps with improving cognition. It improves fatigue. It's a male hormone. So it improves fatigue, cognition, muscle strength, bone strength, mood, but it is not licensed for use for these indications. So there is anecdotal evidence. So if a patient came and told me, oh, I just want testosterone to improve fatigue or to improve muscle strength, I would say that that is not the primary indication to give it, because we don't have enough evidence from studies that it is indicated for that role. And but we have a lot of evidence for improving low sex drive.
Hmm.
So that's why patients, because it's just that testosterone, because it's an unlicensed product, it's unlicensed for use in women. We don't have a licensed product for use in women.
Yeah.
We have testosterone preparations which men use, and we give women 1/8 or 1/10 of the dose. And then we have another preparation which is available, which is used mainly in Australia, which is imported into the UK, and that's called Androfen 1 cream. Again, because it's imported, it's unlicensed. So because they're unlicensed medications, it's on the grey list for a lot of formularies to prescribe. So when GPs go to prescribe it, it comes up as a grey. So for GPs to prescribe, there's something, the indicators like green, gray, and red. So if it's green, they can prescribe. If it's gray, they can only prescribe it if it has been advised by a specialist.
Hmm.
So therefore, unless of course the GPs have undergone training and they are accredited by the British Menopause Society, then they can prescribe it. So sometimes patients, if they can't get it from their GPs, they book an appointment to see me.
Yeah. So what would be the difference between, because some of the symptoms you said that the testosterone helps with, also that sounds like some of the progesterone, HRT, maybe not the sex drive, but like the fatigue, those type of symptoms and stuff like that. So what would be the difference of testosterone and progesterone, or even not?
Okay, so testosterone, so there are three hormones produced by the ovary. We have estrogen, progesterone, and testosterone. Now, testosterone is also produced by another gland, which is called the adrenal gland, which
Mhm.
sits on top of the kidney. Okay. So, testosterone, we know it's an important male hormone, which helps with bone strength, muscle strength, cognition, sex drive. Okay. Now, progesterone is a hormone which actually doesn't, it can have a side effect of causing fatigue. So progesterone doesn't help with fatigue. Progesterone is a hormone which typically is associated with PMS, premenstrual syndrome. So the symptoms of PMS are typically low mood, fatigue, tiredness, bloating, weight gain. So
Mhm.
that is the progesterone hormone. So it, if somebody had these symptoms of fatigue and poor cognition, memory loss, joint pains, aches, we would first we make a diagnosis that is she suffering from the perimenopause or the menopause. Okay,
Mhm.
so we have to make that diagnosis. So a
Would you,
woman
would you,
will,
would you, sorry to interrupt you, would you do that by blood tests then? That's how that's done.
okay, so typically the average age of menopause in the UK is 51.
Hmm.
But the symptoms of the menopause can start from the age of 45 to 55, anywhere.
Yeah.
Okay. So that's the average age, anywhere between 45 to 55. Now, there is a condition called early menopause between 40 and 45. And
Hmm.
there's another condition called premature ovarian insufficiency, which is menopause under 40.
Right.
Okay, so there are three groups: menopause under 40, early menopause is 40 to 45, and typical menopause is after 45.
Right.
So we do not do blood tests in anybody who's having symptoms after the age of 45
Right.
because blood tests are not diagnostic of the menopause. So
Okay.
why are they not diagnostic of the menopause after 45 is because the levels fluctuate a lot. So
Hmm.
the hormone that we are checking for is a hormone which comes from the pituitary gland in the brain. And that hormone is called FSH. So I see a lot of patients I work in a GP practice, and I see some patients where colleagues have done an FSH level, though it's happening less and less now because GPs are now well informed, well educated, and they know when to do the blood tests. So above the age of 45, we do not do blood tests for FSH because the FSH level goes up and down. It has peaks and troughs.
Hmm.
So we diagnose menopause usually when an FSH is above 30. But we know that we can do a blood test in the morning today when it'll be above 30, tomorrow it may be 5.
Right.
So because it varies so much, we make a diagnosis above the age of 45 based on symptoms. And these symptoms are due to declining estrogen levels. And estrogen levels fluctuate a lot again in
Hmm.
this period after 45, which we call the perimenopause. So perimenopause is a time around menopause. When we say the average age is 51, it's a time around that. So the diagnosis is based on symptoms. So typically, a woman can get like vasomotor symptoms like hot flushes and night sweats. But not a lot of women get these vasomotor symptoms. Typically, women will complain of like fatigue, or she may get joint aches and pains, or she may complain of weight gain.
Yeah.
And typically, the weight gain, which is a common symptom, is weight around the mid portion. Okay,
Hmm.
she says that I'm doing the same amount of exercise, walking 10,000 steps, I'm eating healthily, but I'm piling on weight and it's very difficult to shed weight off. So that is a typical symptoms, or they complain of like sleep disturbances or insomnia they can have.
Yeah.
Then they have commonly, like in the ethnic population, they may not have these hot flushes, night sweats. It varies. They may typically complain of low mood. Mood worsens around the menopause, and it worsens more in patients who have a past history of postnatal depression or past history of depression or past history of PMS.
Mm.
Because of the declining estrogen level, the mood worsens. So when a patient comes to see me for a diagnosis, in the history I find out whether they've had past history of depression because I know that they could be on antidepressants and they're not working very well anymore, and the
Yeah.
depression has got worse and they need that little bit of HRT to help that low mood.
Yeah.
Then
Sometimes
yeah,
I've heard that from other people where they've gone to, and I think maybe you said this in when we spoke before, that actually some people have gone to the doctors having low moods and things and end up getting antidepressants
antidepressants,
after
yeah,
the
quite right.
HRT.
Yeah. So it's just making, obviously, patients can be clinically depressed. So we may have to make a diagnosis. Are they clinically depressed and they need antidepressants, or just as a worsening of mood? Okay, that's important because
Yeah.
you don't want to miss a clinical depression with loss of appetite, loss of weight, loss of sleep, and they have suicidal thoughts. We don't want to miss that because
Mm.
that is important to diagnose and they would need antidepressants. But if patients are just having a low mood, a dip in their mood, then they would benefit from HRT, not only for their symptoms, then HRT has other benefits, which we'll go through in a bit. Then typically I had seen an actor during COVID. And during COVID, we were doing virtual consultations. And she typically said that I've lost all my confidence. And she was in the age group of 45 plus. She was 47. And her symptoms improved with HRT. Or patients say that they have brain fog, that we just can't recall names, or teachers are finding it difficult remember the names of their pupils or recall the right name at the right time. So that is again a common
Yeah,
symptom.
definitely. And I think within that, I mean, I know myself that I think I am on month 4 now of HRT, and I can definitely say that maybe at first I was thinking it was placebo, like the brain fog seemed a lot better and forgetfulness was less, and I was sleeping a lot better and things like that. But I think the biggest thing for me was I thought I was starting to become a little bit incontinent. And I realized that I think
Mm.
I was having atrophy. And literally, even on the first month of HRT, the atrophy just disappeared and or like significantly reduced. And I was really shocked. Then I was like, okay, convinced, some of the other things
Yeah.
they placebo, but this was really like, wow, this it stopped because it was really affecting my, like you say, confidence and things like that. Because I was thinking, oh my God, I'm wetting myself. And I'm like, actually, I'm not. It was this atrophy.
Yeah. So we have estrogen receptors in every part of our body. We have estrogen receptors in the vagina, in the bladder, in the uterus, the tubes, the ovaries. So what happens with menopause is there's decrease in estrogen receptors, there's declining estrogen levels, and the tissues in the bladder and the vagina also get affected. Okay.
Mm-hmm.
So the tissues become thin, they lose their elasticity. There's less of collagen. The pH of the tissues changes. In the vagina, the pH changes, so they're more prone to infection. So, what do women feel? We asked this symptoms specifically that do you suffer from vaginal dryness, soreness, discomfort, pain during sex? Do you leak urine? They have an urgent continence, or they leak when they cough, or they leak when they can't get to the toilet. So these symptoms happen because of reducing estrogen levels. And of course, in your case, it improved with hormone replacement therapy, which you were
Yeah.
taking either in oral form or patch form.
But
But in some women, so oral HRT, I mean your systemic HRT, whether you take it orally or as patches, will help these symptoms. But some women need the estrogen in the vagina. So
yeah,
that is where we give local estrogen in the vagina to help symptoms locally related to the bladder and the vagina. So that comes in the form of a vaginal pessary or a vaginal cream or a vaginal ring, which they insert. There are also some oral tablets specially uh, given, like there are hormone tablets like ospemifene, which we give orally. So some people don't want to put stuff in the vagina. So we have
yeah.
some medications which we can give orally, which will improve the symptoms in the vagina. And that is what we ask, that are you experiencing these symptoms? And some women think, oh, I cannot be taking hormone replacement therapy with along with local estrogen. I'll be taking too much estrogen. No, that's not true, because the local estrogen in the vagina works only locally. It doesn't get absorbed into the rest of the body. So it's not going to be associated with an increased risk of breast cancer or all the other worries that they have about the risk of HRT, because the dose is so minuscule. It's like taking one tablet of estrogen in the full
Yeah.
year. So,
And so,
so
so
that
that
is,
so that helps then with some of the symptoms we were talking about, like so maybe like the
yeah,
atrophy, some incontinence, like things around
yeah,
all of that. So it only, like you say, absorbs locally around that area.
correct.
Right.
Yeah,
Okay.
absolutely. So then the other symptom around the menopause, which is important to find out, is so we say a woman is menopausal when she hasn't had a period for 1 year. Okay, so that's
Mm,
a retrospective diagnosis. So the average age is 51. So we say she's menopausal going by the period history. Okay, now we know that around the perimenopause, periods will change. So
yeah.
how do these periods change? The cycle changes. So cycle is an interval between one start of one period and start of the other next period. So the cycle becomes shorter, or they become longer, or they have a few months with no periods, okay,
Mm,
and then they bleed, or they can bleed very heavy. So they
yeah.
bleed frequently, or
That's
they have periods
definitely
have changed and they
that's
become
definitely
heavy.
me. The heavier
Yeah, so
period is
that happens around the perimenopause, around the menopause.
yeah.
So we also take a history of that, because in some women, if there's a period that become a lot heavier, or if they have risk factors for cancer of the womb. So what are risk factors for cancer of the womb? If a woman has a BMI over 30,
Hmm.
okay? So she is obese, she has a BMI over 30. If she has a family history of uterine cancer, Her mother had uterine cancer, she has a family history. If she has polycystic ovarian syndrome, or if
Mm-hmm.
she has diabetes. So these are risk factors for uterine cancer. So if I see a woman who tells me that I've got heavy periods, I will specifically ask her for a family history of cancer. I will look at her weight. I will find out whether she has polycystic ovarian syndrome in the past or diabetes. These are risk factors. And
Mm-hmm.
therefore, in these women, if they have those risk factors, I will have a low threshold to investigate them. I will
Yeah.
refer them for further investigations before starting them on HRT. I will not assume that HRT will make everything better, because then I could be missing pre-cancer or cancer of the womb.
Mm.
Because we know that in women, when they have a high BMI, a lot of the male hormone gets converted to a female hormone, estrogen, in the fatty tissue.
Right.
So therefore, this estrogen causes stimulation of the lining of the womb and pre-cancer and cancer. So I can't miss that. I have to diagnose that, because I
Mm.
would be missing cancer.
And how would
So
you
these women,
how would you rule that out?
so what we do is, first of all, in clinic, whenever anybody has bleeding problems, we examine them.
Mm.
Okay, we find out, we look at the cervix, we check when they've had their last smear, we check whether there could be any sexually transmitted infections, if they've had a recent change in partner. We examine the womb, we check for fibroids of the womb. Is the womb larger than normal? Okay,
Mm.
then what I would be doing is I could refer them for an ultrasound scan.
Yeah.
Some patients require a camera putting into the womb, okay, what we call a hysteroscopy, and they take a little biopsy from the lining of the womb. So they're directly looking inside the womb with a camera, and they're
Mm.
taking a biopsy. So what are they looking for? They're looking for thickening of the womb. They're looking for any little polyps. Polyps are benign
Yeah.
thickening of the lining of the womb. So they're looking for that. They're looking for fibroids. Okay. Of course, the biopsy goes away and we check for pre-cancer and cancer.
Yeah.
Okay. So, but everybody doesn't need a biopsy. We can also do an ultrasound scan to check the thickness of the lining, check for fibroids. And then we have guidelines where if the lining of the womb is very thick, then we refer them for a biopsy, because we want to rule out the cancer.
Mm. Oh wow. So it's quite a thorough
Yeah.
investigation. It's quite a thorough investigation before you would begin to prescribe.
Yeah, but then there are treatments for heavy periods. Like,
Mm.
one of the common treatments for heavy periods, once we've ruled out anything wrong with the womb in terms of precancer or cancer, is a hormone coil. So a hormone coil can be fitted inside the uterus, which has three functions. The first function of the hormone coil is that it's a treatment for heavy period. So it's a licensed treatment for heavy periods. So her periods will stop by the end of 6 months to a year. So that's brilliant. So they get lighter and they stop. The second function of the hormone coil indication is that it's a contraception. So it works as a contraceptive. And the third most important thing, it can be part of her hormone replacement therapy. So hormone replacement therapy consists of two hormones. So if a woman has a womb, she needs two hormones. The main hormone is the estrogen.
Right.
If she has a womb and we give her estrogen on its own, we will cause cancer of the womb. So we can't do that. So we protect the womb with a second hormone called the progesterone. So that second hormone can be given in the form of a tablet. It can be given in the form of a hormone coil.
Right.
So that hormone coil is that second hormone. So if a lady has heavy periods, we can offer them the hormone coil, which can be fitted in clinic. And then we can give her estrogen as part of HRT, which will help her symptoms. So
Mm.
that is how we would treat somebody who has heavy periods and menopausal symptoms.
Yeah. And where does endometriosis and things like that fall into that?
Okay, so what is endometriosis? Endometriosis is where the lining of the womb, instead of being confined to the womb, is found outside. Okay, so if the lining of the womb is found outside the womb, what happens is when a woman gets a period every month, okay, the periods are usually painful, heavy. So when she gets a period every month, that little bit of lining which is lying outside the womb also gets a period every month.
Ah,
Okay. So
okay.
every month that lining of the womb will bleed, which is outside. And then how will it heal? By scar tissue and fibrosis. So that is the cause of her woman's pain in her tummy. So her
Wow.
periods are painful and heavy, and she gets also pain in between periods. And she gets pain during sex because bits of that lining are found all around outside the uterus, near the ovaries. And that is a cause of her symptoms. So why does endometriosis happen? Endometriosis is hormone dependent. A woman gets endometriosis during her reproductive life. She can
Mm,
start with it at menarche. It can continue till menopause. So it is dependent on estrogen hormone because the estrogen hormone causes that lining to become thicker. It proliferates. Okay. So that is what estrogen does. So now in a woman, when she has endometriosis, she could well come up to the age of 45, 50, and she's having hot flushes, night sweats, and she wants HRT. Of course, she can have hormone replacement therapy, but we need to give her the right HRT. So, what would be the right HRT for her? One of the options is having a Mirena coil in that womb. Why? Because that Mirena coil will stop her period. So if she doesn't bleed, that lining which is found outside the womb will also not bleed
yeah.
every month. So we put a Mirena coil and then we give her estrogen.
Mm.
Okay. Now,
Sorry,
yeah,
yeah, Manju. When that's the second option of the coil. So they both stop your periods, but then as you're going into this menopause phase, you don't know if you're having periods or not if you have the coil. Does that matter?
correct. So, it really doesn't matter because these women, they be put in a hormone coil. It stops their period. The hormone coil, as part of their HRT, lasts for 5 years. Okay.
Right.
So, what do we do then is we change that coil every 5 years and we just add estrogen. It just continues with her estrogen and we're
Right.
changing the hormone coil every 5 years. Now, there may be a lady who has a hormone coil in for contraception and say she's 45. Okay. And she says, Doctor, I've had a coil from the age of 40 to 45. And now actually hormone coils last 8 years for contraception. The 5 year rule is gone. They last for 8 years. So say she's had the coil fitted at 40 and now she's 48. And she says, Doctor, I have no periods. How
Mm.
do I know I'm menopausal? That was your question.
Yeah, yeah.
she will she will have symptoms. So the hormone coil is only stopping periods. It
Ah,
has no effect on
okay,
reducing her estrogen.
yeah.
She will yet have night, like anybody else, she will have hot flushes, night sweats, low mood, brain fog, memory, difficulty in remembering, all those forgetfulness, all that she'll have. That it won't stop. So we don't go by the history, we go by symptoms for her.
So it's not just about the periods then. So what if
Yeah.
what if you had what if you hadn't had a period but you were getting up to your 360 days, I've not had a period, and then you have a little bit of spotting, what would that mean? But not a
Okay,
big
so that's a very important
thing.
question because if a woman has no periods for 1 year
Yeah,
and then she bleeds, we call that as post-menopausal bleeding. And that is an indication for a referral to hospital under a 2 week wait, under a urgent referral cancer pathway to rule out cancer of the womb. That is the most important thing. So
right.
if a woman has no periods for 1 year, we cannot just say, oh, you're menopause, and then she bleeds. Even if it is spotting, of course, she'll need an examination. We'll find out why she's bleeding. Is she bleeding because the vagina has become very thin and atrophic? Is there something on the cervix like precancer or cancer of the womb, of the neck of the womb? Does she have a polyp on the neck of the womb? Okay, is there any cause like an infection which is causing the bleeding? But she would need a referral under a 2 week wait.
Right. Okay. And then would that, obviously that's very urgent topic that needs to be investigated
Yeah,
on that
definitely.
side. But would you then after that, does that then take you back to day one again that you're waiting for another year to then say, right, I
No,
Pause.
No,
No.
so it depends. If she has symptoms and she's been investigated, so she has no periods for a year,
Yeah.
she's been investigated, and then she's having symptoms of the menopause, we'll start her on HRT. So
Yeah.
that brings us to which HRT do we give her? So
Yeah.
there are two types of HRT. There is a period HRT and there's a no period HRT.
Ah,
Okay.
okay.
So a period HRT, we give somebody who's still having periods. So
Right.
that is where we take a history. We ask a woman, are you still having periods? Even if there are 3 or 4 periods in the last year. She may
Right.
not be having a period every year, every month. She may have only 3 or 4 periods in the last year. Then we give her a period HRT, which will bring on a period. We have to give her a period HRT for a couple of years, and then we change it to a no bleed. On the other hand, if we have a lady who has no periods for a year, like the lady you just mentioned, then we give her a no bleed HRT. Okay. So a no bleed HRT is one where she'll have no periods, but in the first 3 to 6 months, she'll have irregular bleeding. So when I see my ladies who have no periods for say 1 year or more, so 2 years, 3 years, I say, okay, I'm giving you a no bleed HRT. But in the first 6 months, you'll have spotting. Don't go running to your GP saying you're worried you have cancer, because that will settle.
Yeah.
If it carries on beyond 6 months, then we'll investigate. So there are the two types of HRT, period HRT and no period HRT.
And what's the no period HRT doing for you?
Okay, so the no period HRT, it's just the way we give the hormones is different.
Right.
Okay, so I'll just discuss period HRT first. So period HRT has hormones similar to hormones in her own body.
Right.
So what happens in a menstrual cycle? The ovaries are producing estrogen all the time. Okay, so we give estrogen throughout the month. Then in a menstrual cycle, a woman ovulates. And say she has a 28-day cycle, she will ovulate around day 14, usually 2 weeks before her period. Okay, when
Mhm.
she ovulates, after ovulation, when the egg is released, a second hormone is produced from the ovary, which is called the progesterone.
Yeah.
Okay, so in a period HRT, we give estrogen throughout the month, and the last 2 weeks, we give the progesterone.
Yeah.
And at the end of that, she gets a bleed. And that
Yeah.
happens every month. So that's your period HRT. In the no bleed HRT, we give her estrogen throughout the month and the progesterone throughout the month, not for 2 weeks, the full month. So that is a no bleed HRT. It's a bit like taking the combined pill. The combined pill has got estrogen and progesterone throughout. So
Right.
if I give a combined pill to a girl and I tell her to a lady and say, take it continuously, don't take breaks, she will have no bleed. So
Yeah.
this no period HRT is a continuous combined HRT where she'll have no bleed after 6 months.
Okay. And
So,
is that the kind of thing that you would also give to somebody who had had a hysterectomy and things like that, like a medically, I guess, like a medically.
okay, yeah, so that is like a surgical menopause. So when women have a hysterectomy, they could have a hysterectomy for heavy periods, for she could be having large fibroids, conditions of the womb like adenomyosis. So she's had a hysterectomy. The uterus is removed.
Mm.
We don't remove the ovaries if they look normal. We keep the ovaries because we don't want to be causing a surgical menopause. We don't want to remove somebody's ovaries and take away her estrogen if the ovaries are normal. Because we know that the ovaries work till 51, 52, and some people even till 55. Why would we take away the ovaries? So we
Okay.
don't. Okay. So say we remove somebody's uterus. Okay. So she's having no bleeding because now we've removed her uterus. So what kind of HRT do we give her? She needs only one hormone, which is estrogen. The second hormone, which is the progesterone to protect the womb, we don't need to give her that second hormone because she has no womb.
Don't know him. Yeah.
So it's very good for her because a woman who has a hysterectomy needs estrogen. Now we have good evidence that estrogen only HRT has a lower risk of breast cancer than HRT with both hormones,
Right.
estrogen and progesterone. So,
Okay.
in the days gone by, before the WHI, we thought it was a estrogen, which was a hormone, which was a baddie that caused breast cancer.
Yeah.
Okay. Now we know,
Sorry to interrupt you there, Manju. Just so that I think we can talk about that now, but just so we can outline. So obviously, this is starting to refer to the scare that happened in
yeah,
the early 2000s. So just so that
yeah.
people who are listening are aware what we're talking about.
Okay, so going back to early 2000, when the 2002, there was a large American study called the Women's Health Initiative. And this study hit the headlines that HRT is bad for you. Why is it bad for you? Because HRT causes cancer, it causes breast cancer, it causes heart attack, it causes stroke, and it causes blood clots. Okay, that study was reanalyzed in 2007. Okay. And the reanalysis of the study showed that actually that study should have never even been published,
Hmm.
because that was a study done on women who were older women in their 60s who were using HRT in America. And they were using the wrong type of HRT. They were having oral tablets and they were having synthetic hormones. Okay. And if you give somebody in their 60s who are women who are unhealthy, who have a high BMI, who are obese, who have medical problems, you give them tablet HRT, you give them synthetic hormones, what is it going to do? It's going to cause breast cancer, it's going to cause heart attack, stroke, and blood clots. In the UK, since that study, and in the UK, we give HRT to women not in their 60s for the first time. We usually give it to women who are in their 50s, okay,
Right.
or after the age of 45. We give them, we have stopped using synthetic hormones. We use body identical or biosimilar hormones,
Mm.
okay? If women are overweight, if they have comorbidities, if they have like blood pressure, diabetes, we tend to give them estrogen, not as tablets. We give patches or gel. We
Yeah.
give natural hormone, which is a progesterone. We don't give synthetic hormones
So
like they gave in the WHI.
yeah, so it kind of sounds like it was a self-fulfilling prophecy that literally
Ex-
all of the people basically it sounds like it was a really bad test group.
Absolutely badly designed study. And they
Yeah.
tried to stop the publication. So since that study, they did get useful information from the study. They
Hmm.
found out that HRT, we know it prevents osteoporosis. It's used even for treatment of osteoporosis under the age of 60.
Right.
Okay. We know that HRT is used to control symptoms. Okay. They reanalyzed in that study, the age group of women varied between 50 to 70, 70, 75. They looked at the women between 50 and 60. And you know what they found in that group of women, 50 to 60? They found the risk of heart disease was lower. There were fewer heart attacks and strokes in that age group.
Is
So
that is
HRT,
that
if given within 10 years of the menopause,
be-
protects you from heart attack and stroke.
so is that because of the obviously with having some estrogen lack or lower estrogen can cause like flaring in the arteries and things like that.
Absolutely. Yeah,
HRT helps
very correct.
maintain it, right?
Very correct. So I tell my patients what HRT is good for you. What does HRT do? HRT improves heart function. It opens up the blood vessels. It prevents swelling of the arteries. It reduces the clotting in the arteries. But you have to give the right HRT to the right individual. You
Yeah.
cannot give oral HRT to somebody who's overweight and tell her it's going to protect you from heart disease because it will cause clots.
Yeah.
Okay, so we have to be careful. So then what does HRT do for diabetes? I've had patients in my practice who are pre-diabetic. I've given them HRT because they have symptoms and I've reversed their pre-diabetes and now they don't have it. So
Wow.
HRT helps your insulin to work better. Okay, it improves insulin sensitivity. It lowers cholesterol.
Yeah.
So that is how HRT is preventing heart disease. And of course, it makes you feel better. When you feel better, you're in a better place, you're going to exercise more.
Yeah.
Okay, you're going to
I
make
guess
healthy choices.
is that then like again coming back to the estrogen part where estrogen is a bit of a marker around
Yeah,
helping to stop those kind of things. I'm just thinking, I wonder if any study has been done from when that WHI report was released. Probably there's a lot of women who didn't take HRT around because of that report. Was there an increase in, say, some of the things that you just talked about, like cholesterol, heart?
absolutely. We know that, but the problem is we cannot give HRT if the though we know HRT is good for preventing heart disease,
Mhm.
women before 50 don't get a heart attack.
Yeah,
Women, 1 in 2 women get a heart attack around the age of 60. 1 in 2. What 50% of women die of a heart attack after the menopause. But what are women most worried about? Breast cancer.
yeah,
Only 3% die of breast cancer. So coming back to your question that since the WHI study, they've had a lot of conclusions from the WHI looking at specific populations. But there were a lot of observational studies we have which showed that HRT is good for the heart when given within 10 years of the menopause. So
yeah,
when we give HRT, so then I see patients in practice, and I was seeing a lot of referrals where women were 62, 63 and they lost out on HRT because of the WHI study and the scare from the WHI study. They were too scared to take it. So
yeah,
then these women came forward, they were being referred that, and I still see today, 20 years after the WHI, that doctor, I want to start HRT, but I'm 62, 63, and and their menopause happened at 50. So they are 13 years after the menopause. So what do I tell them? I said, well, they're still suffering symptoms. And some of them have tried alternatives to HRT, and some of them have found that they're not helping. So, what do we do? Okay, we need to counsel them. So, first, we take a detailed history to find out do they have any medical problems. We do blood tests for cholesterol, rule out diabetes. And then, if they're suitable for HRT, check their blood pressure, their weight. We would give them hormone replacement therapy, but give them a low dose. One. Two, we give them body identical HRT. So, HRT, which is similar to hormones in their own body. So we give them estrogen in the form of patches or gel and a low dose. And we give them the second hormone to protect the womb, which is the progesterone capsule. Okay. That they have to take to prevent cancer of the womb. So that is their HRT. If they have vaginal symptoms, we would give estrogen in the vagina.
yeah,
Okay. Then how do I counsel them about the benefits and the risk? So I say to them, that the benefits are there for control of symptoms. It will prevent osteoporosis. If they have osteoporosis after the age of 60, we usually don't give them HRT after 60.
hmm,
Okay, we give them, but if they have menopausal symptoms, I will give them HRT, even for osteoporosis after 60. Maybe they require additional drugs to help their osteoporosis in
yeah.
addition to HRT. Okay, what does it do for the heart? The evidence has shown that HRT will not protect them from a heart attack or stroke because
That
it
age.
was not given in the window of opportunity
Yeah.
within 10 years of the menopause because we gave it after 60.
Sure.
But the evidence from the Cochrane meta-analysis showed that HRT will not do harm. So the whole point in medicine is you don't want to do harm.
Yeah.
So it will not do harm. It may not do benefit, but at least it will not harm, provided we give them the right HRT. So it will not be harmful for their heart.
So from what you're saying, I'm getting the point that actually from whenever you start to experience symptoms to even if you are post-menopause and still experiencing symptoms, it's never too late to seek advice and take
Yeah,
some.
seek advice. I mean, we also have to be sure that a woman's symptoms are due to the menopause. Okay,
Yeah.
there are lots of other causes of symptoms, like fatigue can be due to a lot of causes. Like
Mhm.
I saw a lady who was 42 who was having very heavy periods. And she said, I'm having heavy periods. I'm so tired. And I think it's the menopause. Okay. And actually, her periods were so heavy. She was anemic. Her iron levels were low. Her
God.
hemoglobin was low. And I said, okay, she wanted a blood test because she was 42. So under the age of 45, we do blood tests for the menopause. Or 45, we don't do. So I did a blood test. Blood test came back normal. And then I treated her for her heavy periods. We put in a Mirena coil in. And you know what? She said, all my symptoms have improved. We gave her iron tablets, and her symptoms were not due to the menopause. So, in every age group, whether a woman is 65 and she has symptoms, first you have to make a diagnosis. Not every symptom is due to the menopause.
Yeah. So yeah, that but I just mean that there is options regardless of
Yeah,
your
yeah,
but there's options regardless of your age. And I guess also that's a really good point. You know, all of these symptoms could you can look at a list and kind of go, ooh, tick, 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 that's
yeah,
me. But actually,
yeah.
like you just said, there could be some really underlying other issues that
Exactly that. Yeah,
are
like other causes, there could be other illnesses, joint pains could be due to autoimmune causes, other causes you need to
yeah,
rule out rheumatoid arthritis. And the other important thing is we shouldn't forget how like women can have, their self-help with HR without using HRT. So,
yeah,
a healthy lifestyle, losing weight, reducing
yeah,
alcohol, reducing taking hot, spicy food, you know, all that, reducing smoking, all that will also help reduce your symptoms, your
yeah,
vasomotor symptoms. Your sleep will be better because alcohol, doesn't really help sleep. If you
mhm,
think it, I mean, it's not doing good for your bones. It's a risk factor for osteoporosis, having one glass of wine every day. So there are things which women can do. There are important websites which I would like to inform about.
yeah, definitely. And we can add it in the link afterwards so that
Yeah.
people can
Yeah, like there's a
find
women's
it.
health concern, which is a very, very good website where you'll get a lot of information about the menopause. It's a sister organization of British Menopause Society. So
Yeah.
that has a lot of information.
Yeah. Okay, great. And yeah, please, we'll share that at the end and then I'll add it in the link
Sure.
so everybody can come back. But one thing I wanted to ask actually, Manju, at the beginning was I think, and this is something we talked about a long time ago when we first spoke, I was really interested in your training experience. And I guess it kind of leads into how women can access services within the NHS because some GP surgeries have menopause specialists.
And some don't,
I
yeah.
had some done, and I have to say, I had quite a negative experience at my surgery with the menopause specialist there. But you actually do training within surgeries for GPs,
Yeah.
right?
So I'm a trainer, like accredited by the British Menopause Society. You will not believe it. At the time of the WHI study, 2002, 2004, even after that, I used to do menopause master classes for GPs. And I was like literally begging of them, come and get trained. And that time, like nobody was looking at menopause
They're like, get
because
lost.
they were so scared. They said, no, we're taking patients off HRT. And honestly, when I was working in 1996 in Scotland, we were giving HRT like Smarties, like, oh, please take it. It's good for you. It's good for the heart. And then all that happened about the WHI. So I'm a menopause specialist and I'm employed by a GP practice to see their ladies and all the complex gynae, menopause, contraception all comes to me, which is great. But now there may be there's a talk about having women's health hubs in
Mhm.
in the community where they will have specialists sitting, and there is some funding, though not a lot. And so, well, it will take time to develop, but there
Yeah,
are some very good women's health hubs. Now, the British Menopause Society vision of care was that every GP practice, it's called a PCN. So 4 or 5 GP practices come under a primary care network, and there should be one menopause specialist. And every GP should be able to signpost women to websites where to get help. And of course, in a practice, like at least one GP should be trained, should have a special interest in menopause. That is important.
yeah,
So I'm a strong believer that everybody pays their taxes, and you should have HRT on the NHS
Yeah.
Honestly, it should be available. I can understand complex cases GPs can't manage and they are referred to menopause specialists, but most cases are not complex and can be managed in primary care,
So
you
yeah, and
know.
I guess that's the question I have then somehow, that within the GP, within my local GP practice, I really had, yeah,
Tough
quite
time, yes.
a bad time, let's say.
Sorry.
And it drove me then to the private route. And
Oh
I'm
no.
lucky that I could afford to go down that private route. But, a lot of, I was lucky for that. But like women going into the NHS, like what can they expect? And what can they expect to be able to ask
Okay.
their
So
surgery?
one thing is, yeah, one thing is there is a menopause symptom questionnaire. Okay, that the one I commonly use is called the Green Climacteric Scale. So we'll put that in the
Yeah,
chat at the end. I mean, and download that form. And there are many such questionnaires. Like my website, Navani Menopause Clinic, has a questionnaire. So this questionnaire, download it and record your symptoms. So when you go to the GP, there is limited time. They have only 10 minutes, unfortunately. So download your symptoms so that you know it doesn't take time to make a diagnosis. Do your research. And the important websites are British Menopause Society, Women's Health Concern, menopause.matters.co.uk. They are the three websites which I usually give my patients common, and they can look at it. And then once you've done all your research on it, unfortunately, I'm asking you to do a bit of your own research. I know patients have to literally demand HRT that this is what I want, and then they get it. But I mean, I don't see why women really need to go and see a private practitioner for HRT. I'm a strong believer that they should get it on the NHS. Yeah.
yeah. No, absolutely agreed. But I guess it's just that, like you say, the level of service that some,
Varies. I
and
totally,
yeah,
yeah,
it's tricky, it's difficult. And
that's a problem. Yeah.
so within you've discussed a little bit about the experience that you experience with your clients, but are there really any, obviously, I guess one thing we should say is that everybody's menopause is completely different and we'll all experience things at different times and symptoms, etc. But do you find with your clients there are any common symptoms or issues or things that people feel embarrassed about or they just don't know? Like, is there anything within that?
Okay. So one thing is women are very embarrassed to talk about local vaginal symptoms. So I
Mhm.
think it's important that women are embarrassed. Sometimes male GPs are embarrassed to ask these questions. So it's important to just be forthcoming and you should know that there is treatment available for these conditions like vulvovaginal atrophy. And it's so easy to use. There's no point suffering in silence because treatment is available. That's one. Then commonly, of course, sex drive is another big thing where they're embarrassed to talk about it. Okay, so as I mentioned in the beginning, that if sex
Yeah.
drive hasn't improved with HRT, then we can look at other treatments like testosterone. And we know that sex drive reduces in women from 40 onwards. It's not like estrogen levels, it's not like testosterone levels have dipped further around the age of 50. They haven't. But sex drive does go down around menopause. So that's another thing they're embarrassed to talk about. The other important thing is weight gain. And I would just guide everybody to there are very good videos on lifestyle, nutrition, exercise, weight gain, why it happens around menopause. And the most important take home message, I think, from this podcast would be that after menopause, the risk of heart disease is nearly 40 to 50% higher.
Yeah.
Okay. If one thing women can do after menopause is lifestyle intervention, making healthy life choices so that they reduce that risk of heart disease. It's not about living longer. Unfortunately, when we lose our estrogen, we get problems. Okay,
Yeah.
when we lose our estrogen, that is the time even though we can have HRT, HRT is not a magic pill.
Yeah,
It's
it's not
not
going
going to
to
sort everything.
solve
No.
everything, is it? And I think
Yeah,
that's really interesting because I also earlier episodes where I spoke to a personal trainer and registered nutritionist, and I think the conclusions that we came to was really it's about future proofing your body to be able to do the
absolutely.
things you do today in another 10, 15 years. And I think the things that you've been talking about, especially like with the decrease of estrogen and things like this, it's so important to have the actually Anthea, the nutritionist, her point was having the basic building blocks. And it's like if you have those, you can go from there. But like it's not like a one fits all magic pill. You've got to put
Yeah.
the work in as well. But it also doesn't
Yeah,
be hard work. It can be really simple. And it's just about that kind of, I don't know, walking or, whatever kind of exercise you enjoy. Just
exactly. Just do even little movement, like you want to do weight bearing exercise. I was reading somewhere, even just jumping, you will not
yeah,
believe it, which I didn't know myself. It's sometimes you have to teach yourself to jump again.
yeah,
Like kids, we used to jump. It's so good for weight bearing, jumping,
yeah.
skipping, things like that. But even muscle strengthening exercises, doing Pilates, or even if you do yoga, any little movement, even walking, they are
Yeah.
like walking 30 minutes 5 times a week, or doing squats, doing abdominal curls, any amount, any little bit of exercise is going to
Anything's better than nothing.
prevent. Yeah, absolutely. It's going to prevent heart disease. And muscle strengthening is important because muscle becomes weak. Muscle supports bone. It prevents osteoporosis. So muscle strengthening exercises are very important. And exercise is important not only for heart health, for brain health, for bone health.
Oh,
It
yeah.
makes you sleep better.
Yeah.
It's overall like a winner. So,
Yeah. And
uh,
I was reading about a study and it was to do with I'm saying weightlifting, but like strength training. And it
yeah,
was
yeah,
saying that like actually just that pressure, and I guess what you're saying, the jumping as well, that pressure of impact on your bones, these things
absolutely.
learn
It stimulates bone
it's
formation.
bone formation to help with osteoporosis and things like this. So it's just, yeah, anything little and often or whatever you can manage is really sounds like it's the best option.
Yeah, because 1 in 3 women will have a fracture after menopause. So we need to prevent that.
Oh my gosh, I read something else which I can't even remember now where it came from, and it was saying something like once you go through menopause, if you have a fracture, like within the next 18 months, 50% you die.
Absolutely.
That's
Yeah, there's
terrifying.
a high risk, very high morbidity. And if you have one fracture, you're more likely to have a second fracture. And it's important. Like I saw a patient in GP practice who was age group 46, and she had trivial fractures. Okay, she had trivial falls. Following a trivial fall, she had fractures, and she had two, three of these. So a good thing was they did a bone scan to check her bone density. Okay, and she had osteopenia, so her bone density was low. Now she's had trivial falls, this lady. Nobody treated her with calcium and vitamin D. Nobody. And she has weak bones, osteopenia. She comes and sees me 3 years later because I'm in this practice. She was referred by the nurse. And she said, Doctor, menopausal symptoms. I was shocked when I looked at her history. She's had so many falls after trivial injury. She has weak bones. And the first thing I told her is here is calcium, here is vitamin D. You need 1,000 milligrams of calcium, 1,000 units of vitamin D, so international units. So all my patients after the menopause, I give them details of a website which is called the calcium calculator. So the best way to get calcium is from diet. Okay. And there's a website called the International Osteoporosis Foundation, which has a calcium calculator. And they can see how much calcium they're getting from their diet. Like it's not only dairy products which have calcium. We know that green leafy vegetables, kale, sardines, and a lot of other foods which have calcium in it. So see what calcium you're getting from your diet on a daily basis. Okay. If you're getting less than 1,000 milligrams, so say you get 500 from diet, I tell them take 500 as a tablet. Vitamin D, I tell all my ladies to take 1,000 international units daily. But because this, they can buy vitamin D over the counter, it's so cheap.
Yeah.
And this lady, of course, I gave her a prescription for calcium vitamin D, started her on HRT. Okay. And we'll see how that improves her bone strength. And we'll do a repeat bone density in 3 years. So I'm just trying to say that, like even a family history of osteoporosis, like I had another patient whose mother had osteoporosis. I referred her for a DEXA scan. That's an indication for a bone scan. And her her bones were already weak. So we can pick up things that are risk factors for osteoporosis, which we take in history, like if women have got family history, repeated fractures, they're on steroids, certain medications cause osteoporosis,
Mhm.
certain autoimmune conditions cause osteoporosis. So there are a lot of conditions which can cause it, which we know from history. So these ladies are referred for a scan so that we can prevent them getting a fracture.
Yeah. And actually, that just something we talked about briefly before, talking about the diet and things, different diets and things like that, of like the predominant
Plant
build
estrogen.
of plant estrogen and things like this, and how, yeah, where you live in the world.
Yeah,
Or,
you're right. In South Asian population, Japanese menopausal symptoms are not bad because they have a lot of plant estrogens in the diet. Like I come from India, and in India we have a lot of our diet consists of a lot of plant estrogens, which is in lentils, soya beans. We have tofu. We have legumes, chickpeas, red kidney beans,
mm,
that kind of a diet with a lot of, of course, freshly cooked meals. I mean, the worst thing we can do is have processed food, which
yeah.
is unhealthy. So freshly cooked meal. So all that makes a difference with symptoms because of the type of diet we have.
Yeah, no, absolutely. And I think, like, I mean, that's also something that I discussed with Anthea, the nutritionist. She was
Mm.
very, very, very keen on that. Oh my gosh, Manju, honestly, I think I could go on for days
I
talking to you
think,
about lots of
yeah, we've,
everything, but well, I think we need to wrap up now. But one thing I think I just want to mention, because I know when we spoke before, you were also very keen to point out, and we didn't have a chance to mention this, was that not everybody is suitable for HRT, and there are lots of other options. That I know that that was something you were really keen to stress before. So I just wanted to add that in there. And is that then something that's
yeah.
just something to discuss with your GP or whoever you visit
There are
to?
some patients who can't take HRT because they've had breast cancer or they have a very complex medical history with high risk of blood clots. With high risk of blood clots, we do give them patches or gel. But there are some women where HRT is contraindicated because of cancers, some kind of cancers, not all. One particular one is like breast cancer, or they have cancer of the womb, which is advanced. We wouldn't give HRT because that would cause a risk of recurrence. So there are alternatives to HRT, like there are, of course, antidepressants. Then there are other drugs like clonidine. There's a new drug which is not available on the NHS, which is called fezolinetant. It is Veoza, which we give breast cancer patients, and it stops hot flushes and night sweats. So they are not hormones, you
Right.
know. So there are other treatment options which we can give. Of course, patients can try reflexology and acupuncture and cognitive behavioral therapy. And then there are the herbal products like plant estrogens, which are, I mean, herbal products are like red clover, sage, black cohosh, but I wouldn't advise herbal products to breast cancer patients because at the end of the day, it is estrogen. And these herbal products, just because they're natural, doesn't mean they're safe. Okay, they're not standardized. We have to understand. So there are some which are endorsed by which have a MHRA, a stamp by MHRA called the THR stamp. So there is a product called Promensil, which has red clover. There's Menoherb and there's Menomood. So they are standardized in a way that if the box states it has this product in it, it is present in that amount. While most of the natural products, they're not regulated. So we don't know what it contains.
Hmm.
So we have to be careful. Just because something is natural doesn't mean it's safe.
Yeah. Okay. Yeah, that's really important to know. Okay, sorry, I just wanted to mention that because I know that that was something you were keen, you were mentioning when we spoke before that there are
Yeah.
other options. But oh my gosh, thank you so much, Manju. I really appreciate your time. Just very, very, very quickly, if you were to sum up our chat in three takeaways for the listeners, what would you say?
Okay. The first thing I would say is there is no one size fits all.
Yeah,
And HR, everybody's menopause journey is different. That's important. Uh, Two, there's a lot of information available on social media. I would go to reputed websites such as the one by the British Menopause Society and the one by the Women's Health Concern and Menopause Matters.
I'll put those links
Uh,
in afterwards.
yeah. And what I would say, one important thing is, of course, hormone replacement therapy is there. There are a lot of benefits of it. But if I would I would really urge women to look at lifestyle because the risk of heart attack and stroke is so high after the menopause. Lifestyle intervention has so much of benefits in reducing your symptoms, but also in preventing heart disease, preventing osteoporosis. That is one thing which is a change that we can make. And if you haven't had your well woman check, like your cholesterol checked, your check for diabetes, check your blood pressure, please go and do it. Because this is something like heart disease is something that can be prevented. Osteoporosis can be prevented. It's not about living longer, it's about having a good quality of life.
Yeah. Oh, super. I definitely first, second, and third all of that. So thank you so much, Manju. It's really been a treat.
Thank you so much, Karen, and thanks for inviting me to today's podcast.
No problem. Right then, lovely listeners. This week on Clueless in the Pause, I had a brilliant chat with Dr. Manju Navani about getting to grips with menopause. Let me share some of those key takeaways that might make a real difference for you. It's a message coming through in every episode, but one really worth repeating. Your menopause journey is as unique as you are. There's no magic formula that works for everyone, and that's perfectly fine. What works for your best pal might not do it for you. Dr. Navani suggested starting with simple lifestyle changes, looking at your diet and getting more movement in your day before diving into other options. If you haven't already, I'd really recommend listening to episodes 2 and 3 with Rose and Anthea about exercise and nutrition. There's so much info packed in there that can really help you get started. Here's what really hit home for me though, is trust what your body's telling you. We all do it. Those niggles that we've been putting down to, oh, it's just one of those things. Oh, I'm just getting old. Oh, I'm just really tired. I've been so busy. They 100% need checking out, or at least just listening to ourselves. What is it? What's going on? Why not see if your GP surgery has a menopause specialist in clinic and book an appointment? Another game changer for me was starting to keep a diary on my cycle and symptoms. So, tracking simple things like how long does my cycle last for? How long does my period last? What is my period like? Is it light? Is it heavy? How has it changed? Do you have any PMS symptoms? What's changed over the last years in your cycle? It's worth noting that there are over 140, yes, 140 symptoms reported on menopause, and there are probably so many more, but only one is diagnosable through your GP, and that's hot flashing. So be armed with your facts when you pop in to see your GP. Know your cycle, know your symptoms, and know how you're feeling. So, with that being said, it's worth to take 5 to 10 minutes every day just to note down how you're feeling. It's really simple, but it does help you spot patterns and gives you a proper handle on things when you come to discussing your options. And fundamental is stick to trustworthy websites for your research. Knowledge really is power, and there's so much information out there, but not all of it is always from reputable sources. I've added a link at the end of the episode from Dr. Navani of trusted websites that she would recommend to use. Most importantly, remember you're not on your own with this, and you're definitely not losing the plot. There's masses of support out there, along with plenty of solutions. So, ready to take control of your menopause journey? Let's get cracking. So, if you have any questions from this week's episode, please do let me know. I'm compiling a list of questions to put back to each of the experts for an end of season episode. Join us next week when I talk to Ali at Rebalance You. We'll be talking all things holistic practices and what they can offer through the menopause journey. See you then.